Good afternoon, everyone, and welcome to this webinar on Obesity, Overweight, and Preconception Health, Part 1, Defining the Challenges and Connecting the Partners. Again, my name is Megan Philippi, and I'm a Program Analyst of Women's and Infant Health at the Association of Maternal and Child Health Programs. Before we begin with our presenters, I do have a few housekeeping items. Audio is available through your computer speaker. If you're having any technical difficulties with your audio, please use the chat feature on the webinar interface, and AMCHP staff will be able to assist you. Today's webinar is being recorded. The slides will be available on the AMCHP website, along with a recorded file a week after the broadcast. We will have time after presentations for a question and answer period. We invite you to submit questions throughout the call by using the chat box on the lower left-hand side of the screen. Please send your questions to the chairperson, and also be sure to include to which presenter or presenters you are addressing your question. Finally, you will receive a short evaluation after this webinar has ended. Please take a few moments to provide some feedback, as your input is very helpful in planning future events and learning opportunities. And also just to note, the webinar recording will also be housed on the beforeandbeyond.org website in the news section. I'll now turn it over to Erin Bonzon, who will provide you with a little background for today's webinar and introduce our speakers. Erin?
Thank you, Megan. Hi, my name is Erin Bonzon. I am the Associate Director for Women's and Infant Health at AMCHP. On behalf of AMCHP, I'd like to welcome you to today's learning event. The purpose of today's webinar is to focus attention on the impact of obesity on the health of young women and any future children they may wish to have, as well as to share ideas and strategies for addressing this public health crisis among maternal and child health and chronic disease partners. Our learning objectives are as follows. By the end of this webinar, we hope that attendees will be able to describe the prevalence, population, and trends in obesity and related chronic conditions in the U.S. among women of childbearing age, discuss the clinical impact of overweight and obesity on women's health, pregnancy, and infant health, describe the MCH perspective and opportunities for addressing overweight and obesity, and discuss new approaches to chronic disease prevention and management. We have a great lineup of speakers this afternoon, and I'd like to kick it off and start by introducing Shin Kim. Ms. Kim is an epidemiologist in the Maternal and Infant Health Branch in the Division of Reproductive Health at the Centers for Disease Control and Prevention. Her major research topic areas of interest include gestational-related obesity, weight, and nutrition, with particular interest in the short and long-term effects of in utero exposure to excess glucose on offspring health. She's published peer-reviewed articles on topics including gestational diabetes, maternal obesity, gestational weight gain, childhood growth and obesity, and tobacco use. And with that, I will turn it over to Shin.
Okay. Good afternoon. I'm Shin, and today I will present the prevalence and trends in obesity in the U.S. among women of reproductive age. So here's a brief overview of the presentation. First, I will describe the general population of adults and adolescents by providing definition of weight status and prevalence and trends by age group and race ethnicity. Then I will describe obesity and pregnancy and its relationship with gestational weight gain, gestational diabetes, and large for gestational age. And then I'll wrap up with a brief discussion of obesity implications with chronic disease. For this presentation, I am using the WHO definition of body mass index, with overweight being 25 to 29.9 kilograms over a meter squared, and obese being greater than or equal to 30. So here is an overall trend slide. In this slide, we're examining obesity, defined as BMI greater than or equal to 30, among women of reproductive ages 20 to 39 years of age using NHANES data. This includes women who have not had a pregnancy, who have had a pregnancy, or who are done having children. This is important to note, as women who go on to have a pregnancy are different and deal with different issues. So here, as you can see in this overall population, obesity increased rapidly between the 80s and mid-2000s. And now it looks like obesity may be leveling off in the more recent years between 2009 and 2012. Using NHANES data, we also see that there is great racial and ethnic disparity, with the highest prevalence of overweight and obesity combined in non-Hispanic Black women, and the highest prevalence of just overweight in Hispanic women. In this slide, I'm presenting overweight and obesity among 20 to 49-year-olds in 2005 and 2006 using NHANES data. In this ad hoc analysis, we show that obesity is highest in women ages 40 to 49 years of age, and that obesity increases with increasing age. Overweight is fairly constant across the age groups, around 20%. So next, I'm going to talk about adolescent obesity. And for adolescent obesity, we are using percentiles based on CDC growth charts and referring to those that are 85th to 95th percentile as overweight and greater than and equal to 95th percentile as obese. So unlike women from 20 to 39 years of age, among adolescent girls aged 12 to 19 years using NHANES data, obesity continues to increase. The red line indicates where the Healthy People 2020 goal is, and as you can see, we clearly are continuing to move away from it through all the years. Similarly to women 20 to 39 years of age, the greatest prevalence of overweight and obesity is in non-Hispanic Black girls, with Hispanic girls with the next highest prevalence. This high prevalence in obesity among adolescent girls is problematic as these girls may one day become pregnant. So now I'm going to talk about obesity and pregnancy. Why is pre-pregnancy obesity important? Well, obesity is associated with a number of undesirable outcomes. But in the context of reproductive health, for the mother, obesity has a negative impact on the ability to get pregnant and to maintain an early pregnancy. Risk of miscarriage increases as BMI increases, and GDM, hypertensive disorders of pregnancy, and thromboembolic disorders, in other words, blood clots, are more common among pregnant women that are obese. Obesity can also adversely affect labor and delivery, increase incidence of labor induction, difficulty in fetal and uterine monitoring, increased cesarean delivery, increased difficulty in performing emergency C-sections, increased risk for postpartum hemorrhage, and longer hospital stays. Obese women also have a high incidence of poor lactation and difficulties in breastfeeding. For the child, maternal obesity is associated with increased risk of fetal death, particularly late and unexplained, and some congenital anomalies. Obesity also makes it more difficult to detect birth defects with ultrasound. Obesity does not appear to increase the risk of preterm birth from preterm labor or premature rupture of membranes. However, it is more common. What is more common is that preterm birth due to maternal and fetal complications. Pre-pregnancy obesity are major risk factors for large gestational infants or big babies, and this increases the risk of shoulder dystocia, which is a difficult delivery where the shoulders get stuck. Birth trauma, need for cesarean delivery, fetal distress, need for resuscitation after birth, and admission to the neonatal intensive care unit. High birth weight infants born to obese mothers are also at increased risk for childhood obesity, as well as early onset of medical problems such as diabetes and hypertension. So here's a summary of surveillance data. And these slides show the prevalence of normal BMI across time span from several different data sources. It includes sources such as NHANES, which includes all women of reproductive age, and then also sources such as PRAMS, PINS, and California MIHA data, which are among women who became pregnant. And as you can see here, across all the data sources, fewer women are entering pregnancy at a healthy weight. And again, the red line indicates where the Healthy People 2020 goal is, which is for women to enter to have a normal pre-pregnancy weight of 53.4%. So this slide presents the prevalence of pre-pregnancy weight in 2003, 2006, and 2009 in 20 states using PRAMS, the Pregnancy Risk Assessment Monitoring System data. PRAMS data are among all women who recently delivered a live birth, and they are responding to a questionnaire 3 to 6 months after they have had a delivery. So unlike the enhanced estimates, in this population, you can see that actually obesity is increasing. So earlier in that first slide that I showed that obesity just overall in women of reproductive age may be maybe leveling off, but here obesity is increasing, and the mean percent change, as you can see in the obese women from 2003 to 2006 is about 2 percentage points, and 2006 to 2009 is 1 percentage point. And more specifically, if we look at obesity class, we see that there is an 80% increase in Class 2 and Class 3 obesity between 2003 and 2009, and that nearly half of all obese women entering pregnancy are severely obese. So these slides are to further demonstrate that pre-pregnancy obesity is continuing to increase. And so as you can see, as more states have greater than 20% of obesity, which is in the yellow and the dark yellow colors between 2003 to 2009, you can see that there's more and more of the yellow. So gestational weight gain is a very important component of obesity and pregnancy. It can easily move a woman from normal weight to overweight or obese, or for women who are already overweight or obese, it can contribute to greater difficulty in losing weight after delivery. In 2009, the Institute of Medicine revised their recommendations. One, to be more specific to pre-pregnancy BMI, where underweight women require the most of weight gain and obese women require the least amount of weight gain. Two, they switched over to using the WHO BMI categories. And three, they established a range of gestational weight gain for obese women. However, they had insufficient data to stratify by specific obesity class. So in this slide, I'm presenting the prevalence of gestational weight gain adequacy using PRAMS data in 24 states in 2010. So this is stratified by BMI, which is across the x-axis. And to orient you to the slide, the green bars indicate the proportion of women who gained appropriately, while the red bars indicate those who gained in excess, and the blue bars are those who gained inadequately. So as you can see, over half of women were normal weight. So 51.5% were normal weight when entering pregnancy, and there were approximately equal proportion of these women who gained in each of the three categories. About 23% or 23.6% of women were classified as overweight, and 64% of these women who were overweight gained in excess during their pregnancy. And so overweight women had the highest prevalence of excess weight gain, and then this was followed by obese class 1, obese class 2, and obese class 3. Gestational diabetes is also strongly associated with obesity. Women who develop GDM are at increased risk for diabetes later in life. So this slide shows the weighted probability of gestational diabetes, or GDM, by pre-pregnancy body mass index. And this is by race ethnicity using birth certificate hospital discharge link data in Florida from 2004 to 2007. We have mother's pre-pregnancy BMI on the x-axis and the estimated probability of GDM on the y-axis. So as you can see, the probability of GDM increases with increasing BMI for all racial ethnic groups. There was no clear BMI threshold below which a dose-response relationship was not evident, although the risk of GDM only slightly increased for those less than 20, with a BMI less than 20. Another thing I'd like to just note is that among Asian Pacific Islanders, their BMI or their probability of GDM starts at a higher prevalence at a lower BMI point. So this slide is looking at the adjusted population attributable fraction of GDM attributable to overweight and obesity, again using the linked hospital discharge and birth certificate data in Florida from 2004 to 2007. We wanted to estimate the contribution of overweight and obesity to show the potential impact of obesity prevention on GDM. So if we look at the first column, the overall column, this is essentially saying that you can prevent 41% of GDM cases if overweight, obese women were normal weight, or if you got rid of overweight and obesity. As you can see, this ranged there's a wide range by race ethnicity, but in non-Hispanic Black women and American and Indian women, you can essentially prevent over 50 or nearly half of GDM cases by just eliminating overweight and obesity. So in this slide, we're looking at the population attributable fraction of overweight, obesity, excess gestational weight gain, and GDM on large for gestational age births or large babies. And here you can see that if we prevented excess gestational weight gain, or if you had women gain at adequate gestational weight gain during pregnancy, then you could prevent about a third of large for gestational age cases. And if you got rid of overweight obesity, or if overweight obese women were normal weight, then you could prevent anywhere from 10 to 20% of LGA cases. And then for GDM, you could prevent about 2 to 8% of GDM of LGA cases if you prevented GDM. More specifically, if we looked at this by BMI categories across all race ethnic groups, you can see that even in the normal weight women, you could prevent as much as a third of LGA cases by preventing excess gestational weight gain, or in other words, if you had women gain weight in the adequate category. And as much as 37 to 48% in the overweight category, and then 37 to 43% in the overweight category, and then a little less in the obese category for white, Black, and Hispanic women, but as much as 48% in the Asian Pacific Islander women in the obese category. So why is LGA important? Well, here in this slide, we show that the Z-scores for body weight for children born SGA and LGA. And as you can see, children born LGA increased in size from 36 months to 83 months of age. And further, not only are kids born LGA more likely to be overweight, but kids born to obese moms are likely to be obese. So here you see that only 5% of kids born to underweight moms are obese at 5 years of age, whereas 27% of kids born to obese moms are obese at 5 years of age. Also, postpartum weight retention also contributes to obesity development of women in their reproductive age. Studies show that failure to return to pre-pregnancy weight by 12 months postpartum is an important predictor of long-term obesity. So in this slide, you can see that women who had excess gestational weight gain, which is the top dashed line, have the highest amount of postpartum weight retention compared to those who had inadequate gestational weight gain. And finally, women who are overweight and obese are at increased risk of cardiovascular disease. So as you can see here, diabetes, hypertension, and dyslipidemia increases with increasing BMI. So now what? Well, I think it's important to really emphasize the need to promote healthy weight goals, including a healthy normal BMI before pregnancy, achieving adequate gestational weight gain during pregnancy, and returning to pre-pregnancy weight by 1 year postpartum after pregnancy. The implications for the mom is that this will prevent entering into the next pregnancy obese and preventing future health risks. And the implications for the infant is that it reduces the risk of being large for gestational age. And by sharing healthy lifestyle behaviors with the mom, the infant further reduces risk of future obesity and metabolic abnormalities, which hopefully can stop this vicious cycle of obesity. Thank you.
Thank you, Shin. As a reminder, we will take questions after all of the presenters have finished. I would now like to introduce our next speaker, Ann Dunlop. Ann is a family and preventive physician, maternal child health researcher, and associate professor with Emory University. She serves as a member of the clinical work group of the CDC ATSDR Select Panel on Preconception Health and has a long-standing interest in evidence-based approaches to improving women's preconception and interconception health as a strategy for improving women's health and maternal and child health outcomes. Ann?
Great, thank you, and good afternoon, everyone. It's my pleasure to speak with you today about the clinical implications and considerations in overweight and obesity among women of reproductive age. And the first important point, as has been a bit summarized by the first speaker, is to realize that the health effects of obesity among women of reproductive age are not simply realized by the woman during her pregnancy, but extend to her ability to get pregnant, her ability to have a live-born term pregnancy, to experience complications and even death during that pregnancy, to her long-term health effects, and to the long-term health effects of her birth infant. So it's one of the most impactful conditions that we can address from a public health and clinical standpoint. The range of health effects for the woman and her child are outlined here, and we'll discuss each of these in a bit more detail in the slides that follow. The first is impaired fecundity, or looking at not just the difficulty in conceiving a pregnancy, but more broadly, fecundity encompasses difficulty in conceiving as well as in carrying that pregnancy to live birth. And then we'll discuss some of the increased rates of complications during the pregnancy, increased rates of outcomes of that pregnancy for the woman and her child, and some increased rates of adverse fetal and child health outcomes. So let's start by looking at the impact of obesity on the probability of a woman conceiving. There is strong evidence demonstrating that women who are overweight or obese experience difficulties and delays in conceiving a pregnancy. Specifically, there's a dose-dependent relationship between her degree of adiposity, or her degree of body fatness as measured by BMI or by waist-to-hip ratio, and her time to pregnancy. Specifically, if we look at the probability of conception in a given cycle, it's reduced by 8% in women who are overweight and by 18% in women who are obese. And this translates into an additional 3 months longer for overweight women to conceive and about 9 months longer for obese women to conceive. And that's when we look at all women. If we look at just melliferous women, or women who have not given birth before, these probabilities are doubled. There are several overlapping reasons. We won't go into the details today, but several overlapping reasons for this decrease in their ability to get pregnant. And these include biological effects, such as disruption of the hypothalamus pituitary ovary axis, hyperinsulinemia, both of which contribute to chronic anovulation, which can have long-term health effects for the woman, as well as polycystic ovarian syndrome. In addition, when overweight or obese women do ovulate, they are found to have ova of lower fertilization potential. And then, even in the setting of a fertilized ova, the endometrial abnormalities that can accompany some of the problems with anovulation and irregular cycles can also interfere with implantation. Also, there's some thought that sociobiological factors also contribute to this difficulty in conceiving, such as decreased frequency of intercourse and sort of the partner selection, that overweight and obese women are at a greater likelihood of having a male partner who's himself overweight or obese, who could then have problems with sperm motility and fertility. So kind of a multifactorial reason for this. Also important is the life stage at which obesity onsets. underscoring the importance, in particular, of avoiding the onset of obesity during early life. As data demonstrate that timing is critical. Young adults who are obese, they tend to enter puberty earlier than their normal weight counterparts. And these early maturing girls, it's true, tend to initiate sexual activity sooner, but more likely to have body and self-esteem issues. And also, early puberty is shown to be a risk factor for self-reported depression. Importantly, these obese adolescents are at even higher risk for polycystic ovarian syndrome and its attendant risk for conception and metabolic effects as well. Not only is natural reproduction affected by obesity, but so too is artificial reproduction. There's solid data that obese women undergoing ART, or artificial reproductive technology, require higher doses of exogenous gonadotropins to induce ovulation. They experience retrieval of fewer eggs and lower implantation during the cycle. And they have an elevated risk for spontaneous abortion, even following artificial reproductive technologies and pregnancy complications. And each of these is progressively increased with the degree of obesity that the woman has prior to her conception. So it's definitely clear that there are risks relating to fecundity, or we want to say a probability of conception and carrying that pregnancy through to a live birth. So what do we know about the impact of intervention upon obesity before women become pregnant? Is there any evidence that it works? And indeed there is. Evidence shows that the adverse effects of obesity on fecundity are reversible. And importantly, even achieving a minimal to modest amount of weight loss, even losing just 5 to 10% of the initial body weight, translates to an approximately 30% reduction in visceral adiposity, which is shown to be effective for inducing ovulation in obese women with and without PCOS, to improve their chance of conception, both naturally and artificially, and decreasing their chance of spontaneous abortion should they become pregnant. And I think this slide is really important because sometimes when women are obese, especially as the obesity is increasing, there's a sense that, you know, achieving a normal or a healthy weight is kind of unachievable. So even learning that modest or minimal amounts of weight can have an effect, I think is encouraging for a woman in terms of changing behaviors and for providers. So now let's move on to the effects of obesity upon pregnancy health. Following conception, the obese woman also is at an increased risk for a range of pregnancy complications that can impact her own health and well-being as well as that of her infant. And again, just to reiterate, these include gestational hypertension and preeclampsia, gestational diabetes, shoulder dystocia, obstructed labor, and both of which commonly end in a cesarean section, and all of which can be associated too with an indicated preterm delivery. As well as complications of the pregnancy, maternal pre-pregnancy obesity is also linked with a number of adverse outcomes for that pregnancy, as I mentioned, including medically indicated preterm birth that is resulting from that range of complications we just discussed, intrauterine fetal death, which we mentioned with spontaneous abortion, but as well as stillbirth or death of the fetus beyond 20 weeks gestation, and as well as maternal death. We don't have as strong of data on maternal death, but if we look at the range of studies looking at stillbirth, studies report a 5-fold increase in stillbirth among obese women, and that this risk too is dose-dependent, progressive increase in risk with a longer duration of obesity before pregnancy. So not just degree of obesity, but duration of pregnancy, further underscoring the need to really work on preventing weight gain and early development of obesity and overweight among our adolescents and teens. The birth infant of an overweight or obese mom is also at increased risk for adverse fetal and child health conditions, including congenital anomalies, particularly and strongly neural tube defects, but also cleft disorders and heart defects. as well as macrosomia, which again was discussed by the previous speaker. And that macrosomia is itself linked to several neonatal complications such as hypoglycemia and an increased risk of obesity later in life, thus underscoring the potential for intergenerational effect of obesity among women of reproductive age. Also, later in life, these children born to women who are overweight are more likely themselves to be obese and affected by chronic disease. So again, we've seen that the preconception weight loss impacts women's probability of conception, but what about its impact on these other reproductive outcomes? Well, again, modest weight loss preconceptionally also decreases the incidence of gestational diabetes and the prevention of weight gain between pregnancies, so in that interconception period, also decreases pregnancy complications, again underscoring the critical importance of preconception weight loss for women who are overweight or obese, and postpartum and interconception strategies targeting women to help them avoid the postpartum weight retention between their pregnancies. In fact, there was a recent paper published that did some modeling of national data examining the public health impact of decreasing rates of pre-pregnancy obesity among our women of reproductive age. So in the first circumstance, the model looked at if no U.S. women of reproductive age were obese, probably not achievable if they just want to give us an idea of what could be accomplished. So if no U.S. women were obese when they became pregnant, nearly 7,000 fetal deaths could be prevented, and about 2,800 babies could be born without a heart defect each year. Now, if we look at probably a more realistic scenario in which the prevalence could be reduced by about 10%, nearly 700 fetal deaths would be prevented and 300 congenital heart defects. So again, underscoring the possibility for true public health impact if we were to achieve, even beginning to achieve modest reductions in the prevalence of this important condition. Now let's move on to existing clinical recommendations for screening for overweight and obesity. Presently, a number of national bodies and professional organizations all support that screening for overweight and obesity be performed. Again, the U.S. Preventive Services Task Force has this as a standing recommendation for all adults, with the recommended screening being that calculation of a BMI, body mass index, based on the height in centimeters, or weight in kilograms over height in centimeters squared, and our previous speaker showed you the cutoff values for that, so I won't repeat that. And in particular, ACOG, the American College of OB/GYN, and the clinical work group of the Select Panel on Preconception Care provide guidance that all women of reproductive age have their BMI calculated at least annually, and have even those who might fall into a normal or a healthy BMI category should review medical, social, and family risks for weight-related conditions. Pass that slide. An important point related to the importance of the use of BMI is that it's an objective screening measure, and that's really critical, as studies that have looked at perceptions of weight find that many women in the U.S. who are themselves overweight or obese are unaware of their weight status. They're not seeing themselves as overweight and obese. And these misperceptions are particularly common among those belonging to racial and ethnic minority groups or who are of lower socioeconomic status. And of course, the concern about this misperception is that might interfere with a woman's motivation to begin to change her behaviors to improve her health if she doesn't feel that she is overweight or obese, or perhaps not knowledgeable of the conditions associated with that. So now we'll move on to managing overweight and obesity, and there are solid clinical recommendations for managing these conditions, and including those for women of reproductive age. The first important point regarding this is that weight loss during pregnancy is not advisable for any woman. Regardless of her pre-pregnancy weight status, again, weight loss during pregnancy is not advisable. Thus, the conclusion is that weight loss interventions before pregnancy are really essential to minimizing these obesity-related risks. And both the clinical work group of the Select Panel and ACOG recommend that women receive counseling about the risks of being overweight or obese and what it poses in terms of their own health, their fertility, and their future pregnancy outcomes, and that they be offered intensive behavioral strategies to decrease their caloric intake, change their eating behaviors, and improve their physical activity behaviors. And in fact, to be encouraged to enroll in structured weight loss programs. And as, for the sake of time today, we don't have time to go in depth into this, but this is important to realize that the evidence does support the impact of behavioral strategies in helping women improve their eating and activity behaviors, but those interventions have to be intensive in terms of having a regular frequency over time, as well as a duration of time over which to receive them. And it can't be kind of a simple one-time office visit that you expect to be impactful. It really takes engaging them in a behavioral strategy where they can have ongoing support. Both groups also underscore the importance of preconception counseling for women who are overweight and obese. And the recommendation is shown there, again, just really emphasizing the importance of counseling to help women understand the risks to their reproductive health and their own health that is posed by overweight and obesity, because in fact it is found that the women are responsive to messages around how a given health condition, whether it's smoking, drinking alcohol, chronic disease, can impact pregnancy outcomes, and that can be very motivating for helping women change behaviors. Additionally, there are readily available clinical practice guidelines for both medically and behaviorally managing women who are overweight and obese. And I'll refer you to one available from the American College of Physicians. That's the reference at the bottom of this slide. And these guidelines really begin by emphasizing, again, this behavioral work that has to be part of this intervention. And that behavioral work starts by working with the woman to establish realistic weight loss goals, such that, small successes can lead to the development of self-efficacy, kind of self-empowerment, and then once that goal is achieved, moving on to the next goal. Also, the guidelines underscore the importance of offering specific behavioral strategies to decrease caloric intake and increase physical activity. Not simply saying to a woman, you need to lose 5 pounds or you need to lose 10 pounds, but having her set at least one eating behavior change and one physical activity behavior change as a goal, and helping her take concrete steps or envision concrete steps that can help her achieve that goal, and then having her doing some self-monitoring on her own in terms of how she's doing in reaching those behavioral goals, and not setting the weight loss as the goal, but rather the behavioral change as the goal. The American College of Physicians guidelines also do outline if a woman has a BMI greater than between 27 and 30, essentially, with comorbidities, that pharmacotherapy could be considered. And I've listed the range of medications that are approved in the U.S., although I will point out that sibutramine towards the end of the list is no longer available in the U.S. It was in the American College of Physicians guidelines. So these are the list of medications, if you would like to refer to that guideline to learn more about them. But as you can see, one important thing that may catch your eye is that, those that are used commonly, such as orlistat and phentermine, these are pregnancy category X drugs, meaning they are known teratogens, and some of the others are pregnancy class C, and diazopropion is actually pregnancy class B. So if you have an overweight and obese woman who is, seems appropriate to prescribe pharmacotherapy, considering this pregnancy risk category, if she does desire to become pregnant or thinking about her contraceptive plan, is an essential piece of that. Also, just to point out that the guideline gets very specific regarding the degree of overweight and obesity, and goes on to recommend pharmacotherapy if the body mass index is greater than 30, regardless of comorbidities, and even to consider bariatric surgery if the body mass index is over 40 or greater than 30 with comorbidities. Again, it's more depth than what we can go into today, but just to refer you to that, and also to point out that some guidance that's more tailored to women of reproductive age is available from the National Preconception and Interconception Care Clinical Toolkit, the website for which you can find at the bottom of this slide. And this next slide is really just a snapshot of what that website looks like. The Preconception Toolkit for Clinicians houses a great deal of evidence-based information about a range of chronic health conditions, nutritional disorders, and obesity is found under nutritional disorders, so you can go and get more information there. And we do encourage everyone to check out this website and its resources. When you get to the website, you'll find that the content of the toolkit, there's menus along the left-hand side where you can look at various conditions according to the woman's reproductive plans. Is she desiring to become pregnant, at risk for pregnancy, or not, or sort of unsure, or not desiring a pregnancy? And the guidelines get more specific in terms of working with contraception plans for women according to their pregnancy intentions as well. Again, don't have time to go into that detail here, but would really encourage you to check out that toolkit on the website for more information. There are some special considerations for achieving weight loss among women of reproductive age. For one, postpartum weight retention, as we've seen, is known to be a very important contributor to excessive body weight. And this postpartum weight retention is particularly more common among low-income and minority women, especially those who have already started that pregnancy who are overweight or obese. So a key point here is that interventions targeted in that postpartum and interconception period may be especially important for minority women, and in particular for those who already are overweight or obese. Another consideration relates to the nutrient density of the diet. As you know, we mentioned in the interconception and pre-pregnancy periods, we would be recommending some reduced caloric intake of the women to help achieve a healthier body weight. And you know, there are a number of nutrients known to be of particular importance to women of reproductive age, and it's known that diets less than 1,200 calories per day are likely to require supplementation of these nutrients, in particular folic acid, calcium, and vitamin D. And in fact, even diets greater than 1,200 kilocalories a day may require supplementation of these nutrients, given how difficult it is to meet them, meet the RDA for these through diet alone. So that's an important, the content of the diet and the nutrient content is really important to consider, particularly for women of reproductive age. With a little bit of time, I'd like to say something more about two nutrients in particular, those being folic acid and vitamin D. Folic acid is a nutrient of particular concern as its deficiency during the periconception period is definitively associated with an increased risk of neural tube defects as well as other congenital anomalies. And we know from a recent meta-analysis that neural tube defects and these other congenital anomalies are at least twice as common among women who are obese. And I think that's a fairly staggering number. You know, the reason for this is probably a few reasons for this. Obese women are less likely to supplement with folic acid prior to pregnancy and less likely to ingest folate through food sources. So that's something to pay a good deal of attention to, is the folate status. We care about that for all women of reproductive age, but in particular overweight women. Vitamin D is another nutrient of particular concern because it's associated with pregnancy, its deficiency associated with pregnancy complications of the mother, as well as poor growth of the fetus and later rickets and skeletal problems. And again, it's well established that overweight and obese women commonly have poor vitamin D status, as it's a fat-soluble vitamin, than do women of healthy body weight. And I have a bit more detail on these slides than we can go into today, but I just wanted to have it there for your reference should you want to look back on these slides. Another special consideration related to weight management of obese women is contraception. Of course, contraception is an important part of the health care of all women, including those who are overweight and obese. And sometimes what we find, just like with other chronic health conditions, providers are more likely to shy away from contraception in women with obesity or other chronic conditions. So we just wanted to take some time to point out what the considerations are here. So if we look at contraceptive efficacy, there are some theoretical concerns among women who are overweight and obese. For example, there's been some concern of decreased efficacy of combined oral contraceptions for women who exceed 70 kilograms and efficacy of the contraceptive patch for women who exceed 90 kilograms. But just to point out that our CDC medical eligibility criteria for obesity as a health condition do point out that really all of the methods available to us are either Category 1 or Category 2 methods, and that they can be used essentially either without restriction if they're Category 1, or that the advantages of using them outweigh the risks, and have less of a comment about concerns about efficacy or concerns about safety if that is the only, if we're looking at that condition in isolation. Finally, I know I'm drawing to the end of my time. I just wanted to end with saying, as you've heard from the preceding presentation, obesity is one of the 10 leading health indicators, and you can see that its impact is great upon the nation. And as such, the clinical and preventive and treatment strategies that I presented are, of course, very important, but they should not stand alone if we are to achieve both individual and population-level impacts in reducing the prevalence of obesity and the prevalence of the conditions that it is associated with. And certainly to be effective in reducing these outcomes at the population level, it's imperative that population-based strategies that improve the social and environmental context in which women are living their lives are essential. And that will really lead us to the next presentation, which will focus more on those public health strategies. Thank you very much.
Thanks, Anne. And before we move on, there was a technical question that I think we might benefit from addressing before we move on. There was a request. Could you just explain the pregnancy drug categories in a bit more detail for those not familiar?
Okay, sure, certainly. The FDA, the Food and Drug Administration, provides a pregnancy classification for prescription, well, for medications that get, it is a classification that conveys the risk of using that medication during pregnancy. And the classification system is A through X. And I will start at the bottom because that's the most clear. Pregnancy risk classification X means that is a known teratogen, or a medicine that we know from studies causes birth defects. It's teratogenic or causes birth defects. Going up from there, pregnancy class D means this is a potential teratogen. There's studies that support that it could have an association with birth defects and adverse outcomes. And then pregnancy risk category C means there's some risk of using the medicine, but it's kind of a balance of risks and benefits. Pregnancy risk category A, I'm going back up to the top here, means it's, research shows safe in pregnancy, no real concerns. B is more, shown to be safe in animal studies, not necessarily human studies to support safety, but animal studies supporting it. And there's a great website that I use. I can't give you the exact website, the URL, but I always just Google drugs in pregnancy and lactation, and it takes you to a great website where you can get both the pregnancy classification as well as the lactation classification of medications. It's very useful.
Thanks very much. We'll get that website up for folks too as well. Mm-hmm. And now I'd like to introduce Dr. Sarah Verbies. She will be our next presenter. Sarah is the Executive Director of the Center for Maternal and Infant Health and Research Assistant Professor in the OBGYN Department at the School of Medicine at UNC Chapel Hill. She coordinates the North Carolina Recurring Preterm Birth Prevention Program, a statewide smoking cessation program for pregnant and new mothers, a postpartum visit program, and several projects serving high-risk pregnant women, new mothers, and their infants. She serves on the North Carolina Child Vitality Task Force, co-chairs the North Carolina Perinatal Health Committee, is a member of the CDC Leadership Team on Preconception Health, and serves on AMCHP's Best Practice Review Committee. Sarah?
Thanks, Erin, and hi, everybody. It's great to have so many people on the webinar and to have a chance to really unpack this really important issue. So while there are potentially many opportunities for professionals in the maternal and child health and chronic disease specialties to work together, it's important to first understand more about each other's perspectives, drivers, and directions. So as we go through the next part of the webinar, our goal is to cross-inform each other and also spark ideas about where connections can happen. Because ultimately a win-win is when two different groups can work together toward a common goal, when at the same time they're also meeting expectations in their own field. So I'm going to be offering the maternal and child health perspective, and something that it's been mentioned briefly before, but something that has really caught our attention over the past few years is the increase in maternal mortality, which we know is a tip of the iceberg in terms of also concerns about maternal illness. And as you can see from the slide, we are now experiencing 16 deaths per 100,000 live births, which has significantly decreased our international ranking as a safe country in which to give birth. And of relevance to this particular discussion, as we have done more increased assessment and review of maternal death, the link between chronic disease, particular cardiovascular conditions, has become more evident. And so this increasing contribution of chronic diseases to death suggests a change in the birthing population, and also really has brought this to the forefront of something that we're really concerned about. So traditionally the field of maternal and child health is focused on pregnancy, infants, kids, adolescents, and children and youth with special needs. But over time research has really expanded our perspective more broadly with an increased focus on the health of young women and men, the health of families, maternal wellness, focusing on equity, and also being much more mindful about the conditions that impact health. And while I only have a few minutes, I'm just going to kind of do a little bit of quick highlights on a couple of these key areas of connection, kind of consider them the top playlist, I guess, currently in maternal and child health. So when we think of the risk factors for heart disease, we often think of smoking and high blood pressure, cholesterol, and obesity, so forth. But do we often think about low birth weight? What does low birth weight have to do with heart disease 40 to 50 years later in life? Well, Barker and his colleagues worked on a theory for over 20 years that there are critical periods of development during which the functions of an organ or system are being programmed. And if things don't go right then that organ or system may never function optimally over the entire life course. So for example, if a baby is undernourished inside the womb, especially during the second trimester when the pancreas is developing, that baby may end up with a smaller pancreas than an average adult, and that smaller pancreas may not be able to handle a sugar load as well, which leads to an increased susceptibility for the development of diabetes in the future. So we know that in the womb the baby protects the growth of its brain at the expense of other parts of its body, and so this trade-off can permanently change an organ's function and potentially lead to disease in later life. So there's been a lot of growing evidence that people born low birth weight may have increased risk for chronic disease in the future. In fact, there's a study just published in December 2014 that found that low birth weight was directly predictive of higher risk of type 2 diabetes later in life for the women that were in the study. Well, MCH professionals are clearly concerned about tobacco use during pregnancy to its impact on birth weight, preterm birth, and some birth defects. New evidence suggests a connection with increased risk for chronic diseases for those babies when they grow up. So we can see here that in utero tobacco exposure has been shown to be associated with obesity after adjusting for age, education, and personal smoking, and for hypertension and gestational diabetes in adult women. The NIEHS scientists have also reported that exposure to tobacco in utero can lead to increased levels of triglycerides and lower levels of good cholesterol in adults 18 to 44 years later. Other research suggests that maternal smoking can also program her baby to be at risk for addiction to nicotine in the future. So as we take kind of this concept of the Barker theory, and we look at the life course model, the Barker theory that I just described falls in that arrow that you see at the bottom that says early programming. So the life course perspective is a way to look at life as an integrated continuum. So instead of these different disconnected stages, it's a conceptual framework, and some people even call it a paradigm shift in our field, which recognizes that each stage of life is influenced by the stages that precede it, and in turn influence the stages that follow it. So if you look at the image, you can see along the y-axis is our health potential, and the lifetime is charted on the x-axis. And then you'll see two lines that suggest different trajectories over life. And so as I mentioned before, we've had a lot of concern about equity in maternal and child health. And this model helps us better understand where we see gaps in health equity, both in different phases of life and then over the life course. The green arrows that you see pictured there are protective factors, and we know that the things in our lives such as access to healthy food, strong families, good schools can help improve our health over time, and that risk factors, which are the red arrows, can cause challenges over time. And so this model challenges us to make sure that we are balancing adequate supports and services to counter risk factors over time. So this really has given us an opportunity in our field to think about an intergenerational approach to our work and to start to think a little bit more cyclically about kind of the health of that adolescent woman who may become pregnant and kind of the impact of that pregnancy on her health, the health of her child, and even on the health of her own parents. Something that we've also been working on in our field is development of life course metrics, so that as we start to find ways to apply life course in our practice, that we're also able to have some ways that we can be able to measure progress in our field of maternal and child health. And there are several indicators, life course indicators, that are related to obesity, and we just wanted to highlight those a little bit here, since how we measure change is important for all of us. And so you can see on the slide some of the measures that we have around diabetes, percent of children exclusively breastfed at 3 months, food, nutrition, and physical activity, household food insecurity, etc. And these may be very similar and familiar to some of our chronic disease colleagues. And so just to give a couple of quick examples that kind of elevate this life course theory and also show our connectivity to chronic disease, breastfeeding is really a great example. So we know that there's a very sensitive period of time for initiating breastfeeding. We have a very small window from when the baby is born until that we want to make sure that that baby can eat well, and that breastfeeding relationship is established early. We know that breastfeeding is really great for healthy weight and nutrition for baby. We also know that breastfeeding can be really good for mom in terms of a really effective tool for her to help her return to her pre-pregnancy weight. It's a great relationship builder for mom and baby, which we know have positive effects over time. And we also know that it can be a cancer risk reduction for mom and baby over time. So this is something that in our field we have an obligation to get right, because we know that down the road it can help reduce chronic disease. We also are better understanding that pregnancy is really a stress test for life, and really elevating the importance of ongoing investments in healthcare services for moms, especially for those that had high-risk pregnancy or poor birth outcome. And preeclampsia is one example of really a flag that we as a system should do better at capturing and addressing over time. So as you can see from the slide, that preeclampsia is not uncommon in pregnancy, and that women who have a history of preeclampsia have an increased risk of developing cardiovascular disease, stroke, type 2 diabetes, and chronic kidney disease later in life. And they're also at greater risk of death later in life from some of those conditions. And we know that the risk increases the earlier in gestation that a woman experiences preeclampsia, and also the number of affected pregnancies that she's experienced. So to switch gears a little bit, also in our field there's been a growing recognition of the importance of place and socioeconomic status impact on the health and well-being in our field. And we've known this for many years, and we really are recognizing that issues such as childhood obesity and infant mortality are influenced by factors far outside of the clinic, far outside of prenatal care in the health department, and actually outside of some of our typical MCH scope of services. So we as a field are really challenged to think, how can we do more at addressing the conditions in which our populations live, including neighborhood, education, and poverty, because we recognize that if we want to see and meet our goals for moms and babies, that we have to step out into some new arenas in order to do that. As discussed earlier, there are also a number of factors that we've come to understand that impact birth outcomes, many of which need to be addressed prior to pregnancy or in the first early weeks of pregnancy in order to reduce risk. And likewise, many of these risks negatively impact the health of the woman and also of new moms. So as you can see from this slide, here are some of really strong evidence and also growing evidence of health risks for women and infants. And again, as we've said several times, you can see in clear evidence that there's some direct link with chronic disease and the health of our moms and babies. And so preconception and interconception health, which is really defined as interventions that aim to identify and modify these biomedical, behavioral, and social risks to a woman's health or a man's health in pregnancy through prevention outcome. I did not exactly get that out correctly, but I think you can read the slide and know what I was trying to say. So that's really how we would define preconception health. And so this concept of improving women and men's health prior to conception has really forced people in our field to broaden our perceptions of target audience as well as our strategies, particularly since in some cases we may be working with young adults who want to avoid childbearing and want to avoid needing maternal and child health services. This has also helped us broaden our thinking in our field to meet the needs of new mothers postpartum as well as in between pregnancies. And in our second webinar, we'll be providing more resources that are available to you through the National Preconception Health and Healthcare Initiative. We also have a set of preconception health indicators that we won't describe in detail, but as you can see, somewhat similar to the life course indicators, when we're looking at nutrition, physical activity, chronic conditions, socio-determinants of health, that there certainly is some connection and crossover with chronic disease. Intended pregnancies are more likely to result in healthy birth outcomes than those which were not. And as such, MCHers are increasingly focused on asking this key question: would you like to become pregnant in the next year? And we've really been doing a lot more to educate ourselves about how to effectively counsel and talk with women about a reproductive life plan. A reproductive life plan is basically a set of personal goals about having or not having children, if, when, how many, and how far apart. Reproductive life plans include statements about how to achieve those goals, and they're really based on personal values and resources. And something that we I've been finding is that often young women with chronic conditions may not be asked about their reproductive intentions by their specialists. So as we've seen through all of the prior presentations, that it's really important that we work with these moms around pregnancy, but this group of women may be the least likely to have a reproductive life plan. Also in our field, we are experiencing some important increased collaboration between MCH and Title X family planning, and we're really excited about these guidelines for quality family planning that were just released last year that highlight the importance of preconception health services to both men and women. And we in our field, looking at our home visitors and our case managers, are increasingly starting to address the topic of family planning. And then finally, our last link, over the past 30 years, obesity prevalence has more than doubled among children and tripled among adolescents. And we know that obesity in young children can result in long-term adverse health outcomes throughout the life course, which we've discussed already, and that it can impact an individual's quality of life and drive medical expenditures at the individual, state, and national level. And there has been a recent moderate decrease in obesity in 2 to 5-year-olds. And we feel like this highlights a continued opportunity to affect change, that healthy nutrition and physical activity from pregnancy through a child's 5th birthday can help ensure healthy childhood development and a healthy foundation for future good behaviors. And so essentially, addressing chronic disease through primary prevention via preconception, prenatal, and early childhood interventions has a lot of possibility for decreasing chronic disease among adults, and lots of opportunity for our fields to work together. And with that, I'd like to turn it over to our next speaker, who is going to offer the chronic disease perspective.
Thank you, Sarah. And now let's introduce Jean Alongi. Jean is a public health consultant with experience in national, state, and local level practice. Her professional interests center on building the capacity of public sector public health agencies to effectively address population health through evidence-based practice. Dr. Alongi served in the Public Health Prevention Service at the Centers for Disease Control and Prevention before becoming the director of the Arthritis and Osteoporosis programs in the California Department of Health Services. She has consulted on national and state-based chronic disease prevention and other health promotion activities in the areas of healthy aging, arthritis, epidemiology, and program integration and collaboration. She is the recipient of the Secretary's Award for Distinguished Service from the U.S. Department of Health and Human Services. Jean?
Thanks so much. Hi, everybody. So to quote John Cleese, I guess now for something completely different, I am here to tell you about what's happening in chronic disease prevention and control, primarily in state health departments, and some of the changes that have happened over the last 10 or so years. The hope that it'll help you identify what kinds of opportunities are coming up in the landscape to work across programs and across sectors for the betterment of diabetes and pregnancy. So what I want to talk to you about today is where we are in chronic disease prevention and health promotion, mostly at the state health department level, how we came to be here, and where it's going, what the landscape is changing. But before I tell you about where we are, let me tell you about how we came to be here with some history. In 2006, the National Association of Chronic Disease Directors and CDC's National Center for Chronic Disease Prevention and Health Promotion came together to have an in-depth conversation and workshop about how administratively chronic disease grant programming impacts the way public health is practiced in state health departments. What are the ways that grants get in the way of good innovative work that meets the needs of a particular state? And some of the things that came out of this workshop were challenges posed by a categorical orientation where a state might have instructions about a grant that required an advisory committee for arthritis, an advisory committee for their diabetes work, and an advisory committee for their stroke prevention work that would often include many of the same partners at the state and community level, and so it was burdensome to those partners. They would have plans in all of these different areas that maybe were in conflict with each other at worst, but at best were inefficient because the priorities and activities weren't leveraged across areas. And then things as simple as like having an epidemiology who had to be assigned just to one program rather than somebody who could use expertise across programs in a way that made sense. And so CDC responded to these challenges with some creativity, and they experimented with putting different grants together on the same cycle or even in the same package, the same categorical grants. Some things about these ideas worked, some things didn't. In 2009, they tried the really innovative idea of allowing 4 states to negotiate their entire chronic disease portfolio, CDC-funded portfolio. These 4 states didn't get any extra money to do chronic disease above and beyond what they were all getting in their categorical grants, but they were given the opportunity to look at it across the entire set of awards and think innovatively about how they might structure their chronic disease work. How did what was included in their portfolio beyond CDC funding fit into a structure and operation that could take them into the future. And then they were given a little bit of money to evaluate what they did. Each of the 4 states tried things a little bit differently. We're still seeing releases of some of the lessons learned from those experiments. A couple of the key things are that there isn't one structure for state health departments that is the right one that we should all adopt. That structure needs to remain fluid and dynamic so it can be responsive to emerging needs. That there are ways that public health practice is changing based on the science of public health practice and what we're learning about prevention and systems change. That the old way of doing business in chronic disease prevention is challenged by. So bringing in expertise in health systems and policy and environmental change, strategic communication, evaluation on a broad sense, not evaluation as tied together with basic analysis skills, all came up as being important, and culture change in how we approach the work. The way that we had been funded to do chronic disease before at the state level really engendered a system where when you hired someone into your state health department to work on cardiovascular health, it was very difficult from an organizational psychology perspective to maintain an alignment with the state health department instead of with your project officer at CDC. So there got to be some complications about who do we work for and whose objectives are we trying to make, and how is that serving what CDC needs to see accomplished out of the funding and what the state needs to address for their constituents. Not that it's really important to say here that that isn't a sign that people were selfish about their orientation or not approaching their work in an open-hearted and creative way. It's human nature and organizational behavior nature that was being manipulated in unintended ways. And so how could we address that? And how can we structure chronic disease activities in a way that really leverages all of this knowledge and science to the best effect rather than getting in our way? In 2011, CDC was able to fund all states and territories to look at coordinated chronic disease prevention across all of their work, not just what's funded in CDC, but everything that they need to do in their specific states and territories. This funding cycle was neither as long or as large as originally envisioned, which caused some challenges, of course. But what it did enable states to do was to do some coordinated planning about how chronic disease prevention might happen in their particular state, how partners can be engaged strategically and effectively in that work. How prevention activities will happen, not just what the state will do, but in an entire system that's made up of communities and healthcare systems and community-based organizations and schools, et cetera. How does that work happen? My screensavers just came on and not letting me back in to advance my slides. I apologize. Okay, here we go. And that has now moved on to CDC's approach to categorical funding in a more coordinated way. And many of you, I'm sure, have heard about the 1305 grants that I will talk about here shortly. But the idea is that although the funding for the Coordinated Chronic Disease Prevention Grant doesn't exist anymore, the coordinated approach to chronic disease prevention absolutely does. And the expectation is that states and more at the local level also will be approaching chronic disease in a way that is not categorically focused. So although money will continue to come from Congress to CDC and from CDC to its grantees, with categorical objectives attached to it and categorically mandated reporting cycles and instructions, for example. The idea is that this will sit in a basket of coordination, of a coordinated approach in the health department. There are challenges to this, obviously, that 1305, which in part funds states to work with schools on physical activity, needs to sit in an environment where states are working across all of their chronic disease and linking this work with other work that they're doing. But it's still categorically focused, and it is still a challenge. What I want to talk to you about next, here we go, is some of the philosophies and operating guidelines behind a coordinated approach to chronic disease prevention. One is domains, and these are domains that were articulated by Ursula Bauer, the director of the Chronic Disease Center at CDC, after lots of conversations with folks working in states and communities, and looking at the way grants had been structured in the past about what kind of work was being done and how it was being done. And these domains are epidemiology, working in policy and environmental change, clinical community linkages, and health systems. And her thoughts were that the work that we are doing now in chronic disease prevention is really dependent on success in these 4 areas. And I'll talk about these areas in some depth in a moment. There are also core functions of practice. And so regardless of what domain you're working in, regardless of what categorical subject matter expertise you need to affect a certain objective, there are core functions that every health department should have to be able to do this work. Those are things like communications, policy, evaluation, partnership. This might look like cross-cutting positions in a health department. It might not, and we see it happening in different ways across the country. And that culture change is going to be important, and I talked a little bit about alignment and position bias. These are facts of life in leadership and management journals. So how do we take that knowledge and use that here to support a coordinated approach that's going to be successful? I only have about 5 minutes left to talk with you, but I wanted to spend a little bit of time on the domains so that you can see where there may be some opportunities for you to intersect with your state health department colleagues who are working in chronic disease. I'm going to go through a little bit fast, but you'll have this information on your slides. And of course, I am more than happy to talk to anybody after the webinar if you want to dig in a little bit deeper. These are topics that we wrestle with and are continuing to understand over the course of the last 5 years. So this is a rich area for some exploration. Domain 1 I mentioned is epidemiology and surveillance. And this is where we look at providing data to inform the work that's happening and what the emerging public health needs are for our different state or community. This is important because we need to make sure that the work that we're doing is the work that's needed. This is also making sure that we have the data that our partners need to do the work that they do, that we're communicating with decision makers about the work that needs to be done and how well it's going. Some examples of work in this domain are the traditional surveillance of risk factors, for example. Developing and disseminating data reports that describe multiple chronic disease conditions, looking at return on investment. More and more our partners in the private sector and in the legislatures really want to see return on investment for our prevention activities. We're also looking at linking different kinds of data sets to traditional public health data through Medicaid and other healthcare systems in particular. Domain 2 is environmental approaches. This is where some of the policy and environmental change that we've seen comes into play, making sure that it's easier for folks to make the health behavior choices that they want to make. It's not always just a matter of deciding you want to be healthier. It's how much support is there in the environment that you're living in for you to make that change. Some examples of this are active transportation to reduce obesity. Safe routes to school is a great example of that. nutritional standards for the food offered in schools and child care settings. Secondhand smoke has had some good interventions in this area, and water quality, of course. Domain 3 and Domain 4 are the two domains that come up for me a lot as I'm listening to these presentations. Domain 3 is healthcare systems. Domain 4 is community clinical linkages. Domain 3 is really looking at how health systems, how we can leverage what's happening in health systems to the betterment of population health. And that might be links to quality care. That might be links to for folks who are at risk for diabetes or identified with prediabetes to getting into care sooner. A lot of the structured weight interventions that some of the speakers have talked about at preconception would fit into this domain nicely. And Domain 4, the community clinical linkages, here we see a need to link what's happening in the clinical encounter in the healthcare system with what's happening in the community for people who are at risk for diabetes or other chronic diseases. So in the community we see lots of opportunity for interventions like self-management, like weight loss, like lactation support. How do we link this kind of work to what's happening in the clinic? Some of the things that are happening here are experiments with reimbursement, getting Medicaid waivers, using community health workers and other healthcare extenders. This is a really exciting part of the public health work that's happening in states, and something to pay attention to as it continues to grow. So what's coming is the continued focus, I think, on domain-centered objectives in federal grants, on the chronic disease grants anyway from CDC. The center will continue to align their funding opportunities, I believe, on these domains so that we continue to build this body of work. The systems transformation focus is very important right now. This is where we're going to see the biggest change in health outcomes, not working independently as public sector public health, but really trying to work in the universe as a whole. The whole person, whole life perspective of this, you've heard from the other speakers as well. We want to apply that not just to an individual who is contemplating pregnancy, but to a whole community and to a whole population, that we want someone to be able to access all of the prevention and care needs that they have where they live for the entire course of their life. Not have to come out for different categorical needs or different timely needs, different parts of their life needs or different parts of their family needs, but to live in this more holistic way. And of course a focus on population health outcomes and helping partners who haven't really looked at population health the same way public health does before, really understand what public health brings to support the work that they're doing. So with that, thank you so much, and I look forward to your questions.
Thank you, and thank you to all of our speakers. Megan, can you take just a minute and remind folks the ways to ask questions?
Absolutely. To submit your questions, please type it into the chat box and please indicate which presenter to whom you're addressing your questions. We will flag that and we will pass it on to each presenter.
Great, thanks. And we've got about 6 minutes and we've got 5 questions or so already in the chat box, so let's go ahead and dive into those. There's a question, as a home visitor, obesity and overweight can be a very sensitive issue to address. What kind of language can we use to increase the awareness? I'm not sure who this is addressed to, but perhaps one of the earlier speakers could talk to this question.
Hi, this is Ann Dunlop. I will do my best to answer, but this is definitely a very complex and, culturally sensitive issue. The words you might use might change depending on that, but certainly good focus group work has been done to find that women in particular do not like words like obesity or body fatness, but using the term overweight or just saying, above a healthy weight to convey that the concern about the weight isn't about the body image or about the look of the person or the shape of the body, but that being above a healthy body weight, that there are the concern is for the health risks that are associated with that. But even when I know someone, fits the CDC criteria for obesity, I do not use that word, particularly, with women, because it's a very sensitive word. I do use the word overweight or talk about them being above a healthy body weight for which, or at a weight which we know there are health risks. And others may have, more culturally tailored messages, but I'm just speaking kind of very generically about some of the words that I use.
Thanks. And along those lines, this is for all of the speakers, I think. Where are those evidence-based programs? Where can mothers or women before pregnancy or postpartum, where can they go to find weight loss programs? And are there programs out there that you'd recommend? Especially for those who may be, there was someone here asked about women who may be undocumented or not have the resources to seek out certain programs.
So this is Sarah, and I think that some of that we were going to try to highlight more in the part 2 of our webinar to really highlight and elevate those evidence-based practices. I do know that, for example, in North Carolina, we've had the Eat Smart, Move More campaign that offers 10 very simple, well, nothing's ever simple, right, but 10 very concrete, doable action steps that people can take, such as rethink your drink or turn off the TV, so that there are some things that are out there, at least in North Carolina, that can help people start to take steps towards making healthier choices.
This is Ann Dunlop again, and yes, I was understanding that the second webinar will focus a good deal on those community and public health-based interventions. But just to say something a little more about that, these, tend to be very local, and what women can access and what they can access locally. So, I do not have knowledge of maybe what might be available to you, but one thing that I think is really helpful are two resources. One is a website of the National Cancer Institute. They have their research-tested intervention programs. It's called RTIPS, the National Cancer Institute RTIPS. I'll try to post that in the chat. And what I love about that is you can do it, although it's National Cancer Institute, they put in their database of community-based research studies, they include a number of studies that have focused on changing eating and activity behaviors simply because those same behaviors, as well as obesity itself, play such a role in cancer. So it's a great way to see, what sorts of interventions have been tested in other communities and what has been found to work at the community level. The other resource is the community, the community guide. And again, I'll try to post that in the chat. I'm not very good at posting in the chat, but the community guide to preventive resources, the guide to community preventive services also has an overview of community-based interventions and their components that have found to be effective in impacting physical activity, eating behaviors, and obesity.
Thanks, Ann. And we've got about 1 minute left. There were a series of questions that came in asking for information from studies. So those who are more research-oriented, we'd love your thoughts on these, and perhaps we can gather a list of resources and studies to send out after the webinar. There's a request for information on, are there studies on women obese women who have had bariatric surgery and then later become pregnant? Are there studies on tobacco exposure and secondhand smoke? And are there any studies linking overweight or obesity to the incidence of SIDS deaths? So that's some food for thought for the presenters. We can gather information, send that back out to everybody. And then I think finally to wrap things up, this question is for Sarah. If there was one message you could send regarding preconception and obesity, what would that be?
I think along the lines that Anne was mentioning, and I think consistent with Jean's perspective also, is that really our focus needs to be on helping young women and young men be at a healthy weight so that they feel good about themselves, so that they feel healthy and well and strong, and that is something that's good for them. And I think that that's really where we need to be focusing, is not just because someone could become pregnant, but because being at a healthy weight we know is good for them across their life. And so really I think that that's a really key message. I would say second to that, that this is why it's good to ask about a person's reproductive life plan, so that we can also match interventions if becoming pregnant is something that's very important to someone and we know that they're overweight or obese, and that gives a focus to kind of, and maybe some incentive for them to work towards achieving that healthy weight. But overall for our country, if we could all work at having young women and then be healthier in terms of their weight, it would be great for us as a country. That's kind of broad, but that's my thought.
Great. Thank you so much, Sarah. And with that, Sarah, did you want to say a few words about our next webinar?
Sure. First of all, thank you everyone for listening in today. We are going to have a second part for our webinar where we are going to be focusing on strategies, evidence-based practice, and ideas for action in terms of improving healthy weight, and also for working together across maternal and child health and chronic disease. So we hope that you all will join us for that webinar as well.
Thanks, Sarah, and we'll make registration available for that soon. Before we go, I want to thank everyone for joining us today. Again, the recording of the webinar will be available on beforeandbeyond.org as well as the AMCHP website listed up here. This information will also be emailed to you, and those recordings should be available within the next week. As we close out, you'll be given a short evaluation to complete. Please take some time to provide us some feedback to help inform future learning events. And again, thank you for attending, and thank you to our speakers for your willingness to share your expertise. Operator, you may end the call at this time.
Thank you. Ladies and gentlemen.